Hello, this is Kim Jong-il. We are going to cover the topic U44 L55 extraction cases. It is a case that is class 2 high angle with protrusive lips and crowding. The patient is a 19-year-old female with protrusive lips and anterior crowding. If checking the true vertical line on the subnasale, especially the mandible, is placed posteriorly like this. The lips are canting in the front view. Let's look at panorama and intraoral photos for this patient. The third molar is erupted and the ramus bite on the right is shorter than the left. And there is some crowding in the upper and lower anterior teeth. Let's look at the PA view in the front view. Canting is observed on the lips in the front view, and the right lips are a little raised. What about PA view? As such, the vertical dimension of the right side is decreased. The right side of lips themselves, the mandibular antegonial notch itself, is places on the upper side. When we look at the upper and the lower, the moderate lower crowding is observed. The upper tooth number 6 shows parallel rotation. The lower molar and premolar on the right side are more meshally inclined. On the view from the front, the left and the right side shows class 1 canine and molar relationship, and left side shows half class 2 canine and molar relationship. There is anterior crowding and the midline is centered but a little inclined. Let's look at the skeleton of the patient. ODI is 72.5 plus value because ANS is placed in the lower palatal plane is 73. AB plane angle value would be minus because APDI is placed in the lower arch. APDI is 76 and CF is 73 plus 76 equals 149. In other words, it is a class 2 high angle case. What is a class 2 high angle case? It means that there are some problems in the posterior and the anterior region, and the mandible is rotated postero-inferiorly. It is class 2 high angle and the FMA is large at 31.6 degrees. U1 to lip line is 2.4, normal. UOP is 11, POP is 18, POP is steep. U1 to FH is 129.7 degrees, which means that it is labially inclined. L1 to MP is 99 degrees, and IIA is 99, which means that the incisors are anteriorly inclined. ELUL is 5.1 millimeters, and the lower lip is protruded by 7.1 millimeters. Let's look at the problem lists of the patient. 1. Protrusive lips. Extraction is necessary. 2. Low CF. Extraction is necessary. 3. Anterior crowding. Extraction is necessary. 4. Labioversion of the upper incisors. Extraction is necessary. 5. Steep POP. The lower second premolar extraction is necessary. It is likely to perform the premolar extraction. The problems on non-extraction treatment for this patient are as follows. 1. Protrusive lips. Small interincisal angle IIA. 3. Severe anterior crowding. Low CF combination factor. If the premolar is extracted instead, it is hard to make a class 2 key relationship on the left. Which one should be extracted? U44, L44 extraction, or U44, L55 extraction? We should think over it. This patient has a class 2 skeleton. The dentition is class 1 canine and molar relationship. Why does this happen? Because to compensate for the class 2 skeleton, the lower molars on the right is more mesially inclined, showing class 1 relationship. On the other hand, on the left, because the inclination of the lower molars is small, it has half class 2 instead of class 1 relationship. Class 1 molar relationship is very important. Based on skeleton and POP, we can notice that the patient has class 2 relationship and would have class 1 after the compensation. It means that if POP is steep, it is highly likely to have class 2 skeleton. Steep POP is the character of class 2 malocclusion. What would happen if steep POP is unchanged? The upper incisors are moved more backwards. If we can change POP, the upper incisors can be moved backwards, maintaining aesthetics. If we want to solve class 2 malocclusion, the steep POP should change instead of being unchanged. In other words, steep POP should be flattened. It is called counterclockwise rotation or POP flattening. As POP is flattened, the mandibular chin itself is placed anteriorly. Compressed condyle is unloaded, and temporomandibular joint problem would be alleviated. As such, as it has class 1 molar and canine relationship, many want to extract the upper first premolar and lower first premolar. The goal of treatment is the same. Steep POP should be flattened. If it is able to make it like this by first premolar extraction, treatment is possible. To make it like this, the lower first premolar is extracted. The lower second premolar is more mesially moved by using open coil spring on the tooth number 6 area, and then it can be uprighted. However, treatment like this becomes more hard to predict. In some cases, it is possible. However, it means that it is likely to be a problem case. On the other hand, in the lower second premolar extraction, if steep POP is flattened, especially for the lower first premolar, mesially inclined, if we upright it and close the extraction space, treatment would become easier. To do so, the lower first premolar, mesially inclined, is somewhat uprighted, and the extraction space is closed by using an open coil spring on the lower canine area. Let's check this case by PEG index. Overjet is 5 mm and APDI is 76.4. Canine key and molar key shows half class 2, POP is 18 degrees, and anterior crowding is -8 mm. This patient would be the case for the upper first premolar and the lower second premolar extraction. How can we treat this? I said that when strategic leveling, appliances are attached to the upper second molar later. Appliances are also attached to the lower canine later. Appliances are attached to the upper teeth number 1, 2, 3, 5, and 6, and the lower teeth number 1, 2, 4, and 6. We should remember that appliances should be strategically attached in the initial stage for the upper first premolar and the lower second premolar extraction case. And then, open coil spring is used on the lower canine area. Then the upper canine is pulled, the lower 8 teeth are pulled, and the lower 4 incisors are pulled. And then appliances are attached to the upper and lower tooth number 7 to finish. Treatment is simple, but you should remember all their process. You should treat it as the process mentioned. Appliances are attached to upper teeth number 1, 2, 3, 5, and 6. I use no mini screw or TPA. Appliances are attached to lower teeth number 1, 2, 4, and 6. The initial arch wire is 040 NITI. 016 NITI or open coil spring should be used to canine area in the lower. The upper canine should be pulled backwards. The upper canine is pulled from tooth number 3 to 6 on 016 SS, which means pulling while maintaining UOP. The mesially inclined lower first premolar is uprighted and appliances are attached to the lower canine. Then, the lower 8 anterior teeth are leveled. 14. NITI is applied. The extraction space is closed through a combination loop for upper, and an ideal arch wire with hook is used in the lower. In the upper, the rest of the canine moves posteriorly. And in the lower, power chain is attached to between the hook and the first molar of the mandible. It is preferable to use solder in the lower. I uses welding. When welding, there are some cases where welded parts become loosened. If loosening, spaces would be created. In fact, in that case, it can be tight again by squeezing or clamping. However, there are some cases when we miss the time. If missed, the space can be created like this. If so, we can solve the problem by using 016 SS contraction loop. Of course, the power chain can be used from mandibular tooth number 6 to the other 6 on 016 SS. After that, appliances are attached to upper tooth number 7 and MIOs are applied, and then short class 2, elastics 3, 16, 60Z are used. In the conventional extraction treatment, bite deepening is a problem. However, in the MIO treatment, anterior open bite is a problem. To compensate for anterior open bite, it is preferable for anterior vertical elastics to be used from the tooth no 1 to the other 1 at night. Then, treatment is over. Proper class 1 canine and molar relationship and uprighted lower teeth are shown. Let's look at before and after panorama. The third molars should be extracted later. Before and after PA view, after treatment, the patient smiling with confidence is shown. Before and after treatment ceph are overlapped. The upper anterior teeth are moved backwards. At this point, how does the molars move? The upper molar is moved forward a little, and the lower molar is also moved forward. It is an adult patient, but the chin may be slightly forward. So the patient could be more aesthetic. The anterior teeth, molars are gradually changed to enable orthodontic treatment. Let's look at this patient. CF did not change. ODI and APDI change. APDI change from 76 to 79. It becomes better to a class 1 relationship. However, CF is 149. It didn't change. Especially the high angle type doesn't change. POP is flattened from 18 to 12 degrees. The maxillary UOP is a little extruded. It becomes a little steep. The maxillary U1 to FH, L1 to MP, IIA are all in the normal range. Before and after treatment, the condition is well maintained because the anterior crowding is dissolved in the post-retention photo. We can notice that it is well maintained from before, after, and front photos. Let's review. In U44, L55 extraction cases, appliances are not attached to lower canine, but to teeth number 1, 2, 4, and 6. The upper canine is first moved backward, and the lower first premolar, mesially inclined, is uprighted and leveled. The extraction space is closed by a combination loop in the upper and ideal arch wire with hook in the lower. After space closure, the appliance is extended to tooth number 7 and MIO is applied. In the Class 2 malocclusion, anteriorly protruded the upper anterior teeth are moved a little backwards, and posteriorly placed mandible is moved a little forward by extracting U44, L55. Which cases should we extract upper first premolar and lower second premolar? Skeleton has low CF and Class 2 relationship. And when interincisal angle is smaller than 120 degrees. If the case that Class 2 molar relationship, cusp to cusp or full cusp, or deep curve of SPE, it can be treated like this. If steep POP is greater than 15 degrees, the lower second premolar extraction is preferable. Thank you for watching.